So let's keep moving. So you shift the potassium by giving the D50 with insulin. Then also you give the beta agonist, and you can also use the bicarbonate, sodium bicarb, to also change the pH, and that would also help with shifting the potassium intracellularly. Okay. Then the exact treatment, the real treatment is actually by giving Lasix, and Lasix will actually help. It's for not only for DKA, it's also sodium bicarb is also a treatment for hyperkalemia. It's not like the number one you use, but you should consider it. It will change the pH, and it also would help with shifting the potassium. So to uh, definitely treat the hyperkalemia, you give Kiexilate, this one. The Kiexilate is actually a chelating agent that take the potassium and secrete it with the stool. And also you can give Lasix. Lasix will also help secreting the potassium in the urine. And you want it to improve the volume status, so you give fluids. But in case that was related to chronic kidney disease, you probably should be very cautious with giving any IV fluids, because the patient is having renal failure, so they could not excrete. So Lasix and fluids should be considered only when you have someone able to urinate. If someone on chronic kidney disease on dialysis, probably will not benefit from that. Okay, and the definite treatment is actually dialysis. Either the patient actually on dialysis, so you do the dialysis, or if the patient actually newly diagnosed with hyperkalemia and it's actually life-threatening and you could not control it with the other options, then you move to the dialysis. Okay. So let's move to hypokalemia. So hypokalemia is really what I should say here is one thing exactly. Any cardiac patient, you're concerned about the patient that he might develop or she might develop ventricular tachycardia, ventricular fibrillation, you should keep the potassium above 4. So never accept potassium below 4 for a patient with high risk of developing ventricular tachycardia, ventricular fibrillation. That is really the enemy of the arrhythmia, ventricular arrhythmia. So always keep the potassium around 4. Okay. So renal loss. So how you will lose the potassium, as we just said, if you have diuretics, loop diuretics is the big one that would make you lose the potassium. If it's you are vomiting, if the patient is vomiting or having really severe diarrhea, that also would affect the potassium level. And the metabolic acidosis. So we said, sorry, alkalosis. So we said the acidosis would lead to hyperkalemia. Alkalosis will lead to the opposite, to hypokalemia. ECG changes, as we said, VTAC, VFib is the big ones, but also the beginning will be you losing the T wave. So T wave, flattened T wave, the T wave will flatten, and also you will develop the U wave. So some people will see the U wave and think it's actually the T wave, but it's actually flipped, inverted T wave. But that's actually depends on are you thinking about the hypokalemia? If you're considering hypokalemia, then you would think it's actually flattened T, then the U wave developed after that. And also it can lead to prolonged QT. Okay. The management. So you need to replace the potassium, right? And the key here is to remember that every 10 milliequivalent of potassium, so every 10 unit or milliequivalent of potassium will give you 0.1. So let's say the potassium is 2.8 now. I want to replace the potassium and take it up to 3.5. So I have to take it up by zero point 0.7, right? I need to add zero point 0.7. So by that, I will reach the 3.5. So then I need to give 70 milliequivalent of potassium. Okay, so each 10 will raise your potassium by zero point 0.1. Okay. Hypomagnesemia is really critical. Magnesium plays a big role with all the electrolytes, but mainly with the calcium and the potassium. So whenever you have patient with chronic hypokalemia and is kind of not responding well to the treatment, then consider checking the magnesium to, to, to see if it's actually the reason behind this poor response to the treatment. So check the magnesium when you have hypokalemia because it helps the potassium to be delivered inside the cell. Okay, then hyponatremia. Hyponatremia is actually as we said, it's CNS related, altered mental status, confusion, delirium, behavior changes, anything CNS related, think about the hyponatremia. Have it high in your differential diagnosis. Normal potassium is between 135 to 145. And it depends, as I said, from one lab to the other, there is a small difference, but that's around the average for most of the lab reference ranges. Causes for hyponatremia, you have, so think about the volume first when you think about hyponatremia. Do I have normal volume, so euvolemic, or hypervolemic, or hypovolemic? So if you have, so let's think here, this bottle of water, I have salt inside, sodium inside, and this is the normal for the sodium in the body. If I increase the water inside this bottle, but I am not adding any sodium, then that would make my body having hypervolemic hyponatremia. I did not add any more sodium, but I actually added more fluid. So that's what happens when you have congestive heart failure, when you have liver cirrhosis, when you have nephrotic syndrome, or you have chronic kidney disease. This will happen. The body will have third space, will have more fluid inside the body, but the sodium is not actually increased to justify the change in the volume uh, regarding the fluids. So you have hypervolemia, but the sodium is still the same as before the hypervolemia. So we consider it hyponatremia, hypervolemic hyponatremia. The other way around, if I have this bottle, this is the normal. So I added more salt and I removed some water. So I removed some of the water and I added more salt. Then in this case, actually, it's a hypovolemic sorry. No, let's go back. So I removed some of the water and I removed some more salt. So I removed more salt and I removed a little bit of water. So I have still water and the salt removed more than the water. So you have hypovolemia because the volume you have actually affected. And at the same time, the salt actually secreted and removed from the body more than the water you lost. So you lost both, but you lost more salt. That's why you develop hypovolemic hyponatremia. And this is a really special case. Most of the times, it's actually related to adrenal insufficiency. When we think about adrenal insufficiency, think about it when you have a patient chronically ill, sick, chronically ill patient with multiple comorbidities, or patient is actually taking steroids for a long period of time and suddenly stop taking steroids. Uh, these are the like common cases. Patient in shock, sepsis. These are the patients would probably have adrenal insufficiency. And adrenal insufficiency is very characteristic. Most of the time, those patients will have low blood pressure. They will have hyperkalemia, so the potassium will be high, and the sodium will be low, hyponatremia, and also they can have hypoglycemia. They will have low glucose. So potassium is high and sodium and glucose is low. High potassium, low sodium, low glucose. And blood pressure usually borderline or low blood pressure. When I have this clinical picture, I should think about possible adrenal insufficiency in my patient. Okay? Sometimes it's actually related to some diuretics. If they take too much diuretics and they're losing more salt than water, then the patient can develop hypovolemic hyponatremia. Management, so for the low sodium, we need to correct the hyponatremia. So you need to give sodium, usually by giving normal saline. But if the patient actually become really like altered and unable to protect the airways, then you have to intubate and consider, or if the patient actually seizing, develop seizure, then you have to consider giving the 3% saline, the hypertonic saline. As we know, the normal body, the sodium inside the body is about zero point 0.9 out of the percent of the fluid. So that's why the normal saline is actually zero point 0.9 sodium. But if you are raising that percent from zero point 0.9 to 3%, then this is when you have to say it's hypertonic, saline with 3% of sodium inside. And when you give it, this is ICU resuscitation ER medication. You never give hypertonic saline in floor bed or in the outpatient clinic, except if like the patient is crashing, seizing, and you are taking the patient to the ER. You can start it if you know how to use it, because very critical medicine. Uh, you should use it cautiously and you give it slowly over 10 to 20 minutes. You use very small amount, around 100 cc, and you give it slowly over 10 to 20 minutes. So critical. Okay. All right, hypercalcemia. This is also a big one. And the relation between the calcium and the albumin, or the calcium and the protein, is really important. Usually, when you have calcium inside the body running in the blood, it will be attached to the protein. So the free calcium, the ionized calcium, is limited. The number of like the amount of the free calcium, which is the ionized calcium, is limited. So that's why you have to consider this relation. If I have patient with low albumin or low protein level in the blood, then I would expect that ratio to change. So I will have more free calcium. The ionized calcium might be normal, but the attached amount of the calcium is affected because there is nothing to attach to in the blood. So that's why you always check the albumin level before you decide about the hypercalcemia or hypocalcemia, to do the calculation and confirm that your ionized calcium, which is really the one can affect your body directly, is affected or not. So you always check the albumin and then calculate the ionized calcium, then you can tell. And some labs will actually provide you with the ionized calcium directly. They will do the work for you. So big causes for hypercalcemia is malignancy, breast cancer, lung cancer, kidney cancer, and the hyperparathyroid hormone. So when you have hyperparathyroid hormone, that would increase your calcium. So we have the parathyroid hormone and calcitonin. Those act against each other. And when you have one high, the other one will go low, and just they act accordingly. to manage the calcium inside the blood. So granulomatous diseases, medications like, as I said, thiazide affect the sodium and the calcium, estrogen and vitamin A, vitamin D toxicity. So the big ECG changes with the hypercalcemia is so hypercalcemia narrow. I remember it this way. When I have the calcium, the relation between the QRS complex and the calcium is the opposite. I have high calcium, then the QRS complex would be narrow, and the QT will be short. So it have an opposite effect. Other than the hyperkalemia will give you wide QT, wide QRS complex. The hypercalcemia will do the opposite. Hypercalcemia, then you have short QT, short, narrow QRS complex. And it also can lead to bradyarrhythmias, bradycardias, okay? So the management, very critical in the emergency room. Whenever you suspect hypercalcemia, then definitely go with the IV fluids. Give big amount IV fluid bolus of IV fluids, normal saline most of the times to help lower slowly the hypercalcemia. Then you can give Lasix. Lasix, as we said, Lasix will actually get rid of the. I think there is a mistake in this slide. Lasix also in the causes, which is not right. Lasix is actually treatment. So please cross the Lasix up in the medications where you have the causes of hypercalcemia. So it's actually the treatment for the hypercalcemia. So you give it and you remove the calcium from the body by urinary secretion. Bisphosphonate and the calcitonin both are actually helpful to lower the calcium, but not like acutely. In the emergency room, usually you will give the IV fluids, then Lasix. When the patient gets admitted, then they will give the other medications, the calcitonin and bisphosphate. Okay. All right. Let's keep moving. Any questions?
Hello, doctor. Good morning. Can you hear me?
أتمنى تكونوا سمعتوا كل اللي قلته لأنه في نصف المحاضرة بعضكم قال إنه صوتي كان غير مسموع. هل عندكم أي أسئلة؟
Yes, doctor. Can you hear me? Hello? Doctor? Doctor, can you hear me?
Calcitonin. Calcitonin, as we said, it actually acts against the parathyroid hormone. So
hello, doctor.
Lowering the calcium level. Okay.
You can't hear me?
Any other questions?
Yes, doctor, I got a question. Can you hear me or not?
عادي ممكن تتكلموا. اللي بيتكلم عنده أسئلة يفتح السبيكر. يعافيكم.
Hello? Doctor? Can you hear me?
ماني سامع والله.
Hey.
أحاول أشوف.
Hello?
ممكن عندي السبيكر ما أسمع.
Hello?
خليه يحاول يدخل معك ويشغله. تكلم الآن يمكن أسمعك.
Hello?
يا الآن أسمعك تفضل.
السلام عليكم دكتور كيف الحال؟
وعليكم السلام حياك الله. علي؟
اي علي الله يسعدك.
اي تفضل يا علي.
would you please like get us a scenario that how we can like manage all of these electrolytes? Because I didn't understand you. Like the first line, we have to like insert normal saline. When to recheck the serum, like urinary serum or plasma serum, every
Sure,
2 hours, every 3 hours to check, or when to do the ECG again.
sure, sure.
Hopefully, you got me.
Yeah, yeah, that's actually can help. Let's take a scenario. So we have a patient. He's let's say 56-year-old male with a history of diabetes, hypertension, and concerns regarding his kidney function in the last visit to his primary healthcare doctor. Came into the emergency room breathing really deep and so fast, and you're concerned that the patient is actually having increase in the work of breathe, and he is tachypnic. So you talk to the patient and you say, what's happening, how I can help you. ايش اللي صاير يا ابوي، ان شاء الله خير. يقول لك والله يا ولدي ماني قادر اتنفس وحاسس اني ما ادري، عيالي تركوني في الشارع وما اعرف، زوجتي تتضارب معايا طول اليوم وما اعرف ايش اللي صاير. تقول هل معك احد؟ يقول اي معي ابني. تروح تسال ابنه وش صاير، يقول لك والله هو له يومين يا دكتور ما يفهم ايش نقول له ولا وش الوضع، حاسس انه هو كانه وعيه تغير، ما هو فاهم ايش نقول له. على طول you have to think about what you have to think about electrolyte disturbance. He's
Doctor,
confused. Yeah.
sorry for interrupting you, but would you please speak out loud a little bit? We can't hear you.
Okay, so let
I
me.
think probably something wrong with your mics, or
Is it better now?
still the same. Nothing has been changed so far.
Is it better now, guys?
Still.
Okay, so let's see. Right, the high definition. All right, is it changed now? I'm actually trying to adjust. Okay. Do you guys hear me better now?
No, actually, still, but you can carry on. There is no other way. Yeah.
Okay. All right, let's see. All right, we should work on this in the next lecture. So let's keep the talk for the next lecture. We'll have 10 minutes break and we'll rejoin. Okay. يلا يعطيكم العافية، نشوفكم بعد شوي.